Welcome you all to today's very important session with a very important topic. Our today's topic is non-critical care respiratory therapy in COVID-19. Wise utilization of available resources is the key. Our today's topic is very important in circumstances of this COVID era. Today we have with us a dynamic physician from two great countries. Our today's speaker is Dr. Barney T.J. Isaac, Professor, Department of Pulmonary Medicine, Christian Medical College, Vellore. And today with us, our today's chairperson, Dr. Mohammad Robed Amin, Professor of Medicine and Line Director, Non-Communicable Disease Control, Director General Health Services, Bangladesh. Now, let me introduce our today's speaker. Dr. Barney did his MBBS from Christian Medical College in year 2003 and did his DNB in Respiratory Diseases 2009 from Christian Medical College, which is very renowned institute of India and also this subcontinent. He was also treasurer, then general secretary and president of the Students Association of Christian Medical College, Vellore. So you can understand how popular he was during his student days. He has got special interest or clinical expertise on ILD and sarcoidosis, sleep clinic, neuromuscular disease clinic. He was invited to give lectures in conferences and workshops in national and international arena. Hopefully, someday he will be in Bangladesh to give his wonderful talk among us live. He attended many special workshops. He acts as guide or co-guide for many postgraduate or postdoctoral thesis. He received Philip Simon Undergraduate Prize exam in psychiatry, third prize in the Dr. J. Kochari Young Scientist Award, top SAS Trainee Award for the year 2014 in UK. He has got many research publications in Index Journal. Now, to welcome our today's speaker, Dr. Barney T.J. Isaac, I like to invite our today's chairperson, Dr. Mohammad Robed Amin sir, to start the session and invite our speaker. Over to Professor Mohammad Robed Amin.
So thank you, Dr. Ehsan Khan, for inviting us on this particular evening, a nice evening, I would say, to present an important topic on the part of non-critical care, wise utilization of available resources. It's a pleasure actually to see Dr. Isaac, and we'll be eager to listen to all of you. And I'm inviting all our physicians as well as students, very eager to present a very important topic in the eve of the COVID-19 and by a very honorable, respectable professor. Professor, floor is yours. I mean, you can start the presentation without any delay.
Thank you very much, Dr. Hassan Khan, for your invitation, and Dr. Mohammad Rabid Amin for your words of introduction and inviting me to be part of it. I'm really humbled and privileged to be in this. I've heard from many people that this is a very vibrant group of physicians. I'm so glad to be here. I'm here to share more of my experience, which we learned from patients and as from colleagues as we went through this very unique time of COVID, where the entire world was caught unprepared. But then over the last 2 days, we learned so many things in respiratory care, which is the most important system that is affected in COVID. And I'm here to share some of those insights, and I'm here to learn. Respiratory care is costly when it goes to invasive mechanical ventilation in COVID, and the outcomes are not that impressive. So it is very important to treat these patients when before they enter into critical care or require invasive mechanical ventilation, and that is a strategy that will help in helping more patients and saving more lives. So what does non-critical care respiratory care involve? I've divided it into three aspects. One is for the patient, two is for the healthcare professional, and three is for the institution. So I've divided it into what this means for the patient, what it means for healthcare professional, and what it means for institutions as a whole. For the patients, the interventions would be what is best termed as awake self-positioning, oxygen therapy, and non-invasive ventilation. For the healthcare professional, it is what we need to do to decrease the risk of infection to the healthcare professionals who are taking care of these patients. The support services that are required, which includes you cannot just leave just doctors or just nurses to do the job. It requires probably respiratory therapists, physiotherapists to be all involved in the treatment of respiratory care aspect of COVID. Otherwise, it becomes very stressful, and hence it's important to look at the mental well-being of the healthcare professional, arrange shifts in a way when those who are on COVID duty should not be mixed with regular duties at the same period, and so on. And for the institution, what it involves is, I don't know about Bangladesh, India went through a time of crisis from terms of oxygen availability, and hence oxygen conservation measures are extremely crucial to be able to deliver what is appropriate with the available resources. And of course, we need to pool resources, and we need to adequately and appropriately train individuals because we are facing COVID ARDS, which is different from other ARDS. NIV, which is usually given for type 2 respiratory failure, which is carbon dioxide retention, is now being used in type 1 respiratory failure, which is hypoxia. So this requires training of therapists, nurses, and physicians to be able to take this forward. Today, I will be focusing on the blue highlighted areas of non-respiratory, non-critical respiratory care. So the overview of my talk would involve some bits of physiology, because I understand that I'm speaking to a diverse audience. It's important for all of us to be on the same base to understand the physiology of what happens in COVID, particularly with respect to the respiratory system. We are going to look at some improving options under which we look at awake self-proning. It's oxygen that comes into the alveoli and diffuses to the blood vessels, which take it to the rest of the body, and carbon dioxide is returned from the blood vessels into the alveoli and breathed out. This is a simple way to explain gas exchange. But if you go into it a bit more detail, it goes by Fick's principle. Now, by Fick's principle, by the formula that is given below, the diffusion, the quantum of diffusion of a particular gas is dependent on, one, the diffusion constant. Now, this differs from gas to gas. It's important to remember that carbon dioxide has 20 times higher diffusion constant compared to oxygen, which means that carbon dioxide is 20 times more diffusible across the alveolar endothelial membrane as compared to oxygen. This is very important to understand, because this will explain why some diseases retain CO2, whereas other diseases have problems with hypoxemia. The second is the what diffusion is directly proportional to is the partial pressure gradient between the concentration of gas in the blood vessel, that is the capillaries of the lung, and the alveoli. More of the gas is concentrated in the blood vessel and lesser in the alveoli, more will diffuse that way. More oxygen is in the alveoli, less oxygen in the blood, more oxygen will diffuse from the alveoli to the into the blood vessels. The third aspect that determines how much diffusion of gas happens is the surface area. Now, by surface area, it is the amount of capillaries that are available and the amount of alveoli that are available to exchange the gases. Now, this can, when there is disease like COVID pneumonia, it affects, we know that COVID is an inflammatory process in the lung, which affects the alveoli, and it affects the inflammation also goes on into the vasculature, causing vasculopathy and decrease in the caliber and availability of blood vessels by microthrombi. So there is certain amount of area that is decreased, which is normally available between the endothelium, the blood vessel, and the alveoli. So it actually decreases the diffusion of oxygen. And the fourth thing that determines it is time. Now, when there is more time that is available, more diffusion will take place. If there is fast movement of RBCs across the alveolar endothelial membrane, then only less of oxygen will be able to diffuse. Now, the factors that contribute inversely are one, thickness of the membrane, and this is classically seen in a spectrum of interstitial lung diseases where there is thickness of the endothelium alveolar interface, because of which diffusion is affected. And the second is distance between the alveoli and the capillaries. Again, partly contribute. Okay, it's coming. I'm sorry. There is for some reason the internet is getting terribly interrupted. I'm not sure why. I'll just see for another couple of minutes. If not, I'll move to another network and come back. The oxyhemoglobin curve moves to the left in when there is decreased temperature, when there is hypocarbia, decreased 2,3 DPG, and when there is acidosis. Now, in COVID, what happens is that if you see COVID patients, they are hypoxic and they are extremely tachypneic. And if you do a ABG in them, they often present with respiratory alkalosis. Now, in respiratory alkalosis, the pH is high and the CO2 is low. Both these are factors which move the oxyhemoglobin curve to the left. Now, because of this, what happens? Now, suppose you have a saturation of a patient is 90%. Normally, the PaO2 correlation is 60, which is here. But when the curve is over here on the left, because of respiratory alkalosis, both because of hypocarbia and low pH, for a 90 saturation, if you follow my cursor, the PaO2 will be actually 40. So actually there is hypoxemia, but there is a falsely normal saturation that is documented because of this phenomenon. Now this is important to understand because when we are managing patients, it's important not only to target saturation, but also to target the PaO2 levels. At least once in a while, we probably need to do a ABG where available and ensure that the PaO2 levels are normal. Now, in a physiological response to hypoxia, we have what is called increased work of breathing. Now, this is a patient who is breathing hard. Now, breathing hard can have two components. One is breathing fast and the other is breathing deep. So, breathing fast is tachypnea and breathing deep is increase in the tidal volume or hyperapnea. Now, when sometimes these patients breathe fast without increasing the tidal volume. So, there is an increase in the respiratory rate, but the minute ventilation, which is the product of the tidal volume and respiratory rate, remains constant, which means they are taking rapid, shallow breaths. It doesn't help in the oxygenation because actually the minute ventilation is divided between anatomical dead space, that is right from the mouth, the trachea, bronchi, and the initial segments of the up to the respiratory respiratory alveoli till which alveolar ventilation is not happening. Only when the terminal alveoli and the terminal bronchioles are involved, there is alveolar ventilation. So in rapid shallow breath, it actually increases the dead space and decreases the alveolar ventilation. Actually, that can affect oxygenation even further. What does improve the oxygenation is when someone is breathing deep. That increases the alveolar ventilation and hence diffusion of gases. Now, this was an article where this terminology, which is often talked about in COVID, called happy hypoxia, was described with its mechanism. But what I want to focus on in this diagram is that tachypnea in COVID is multifactorial. As you can see here, there can be stretch receptors, there can be chemoreceptors, stretch receptors in the lung, peripheral sensors. There is a component of anxiety, brain involved in producing tachypnea. So what we need to understand is tachypnea does not always translate that patient is having severe respiratory distress and is so breathing fast. We need to keep that in mind while addressing these patients, because if we try to target the tachypnea, it will not always work and we will be increasing supports without meaningful outcome. Now, this was a study which tried to look at work-off breathing scale. So, work-off breathing is actually what is not good in two ways. One is work-off breathing is what is a response to hypoxia in the true sense. And secondly, when someone is breathing very fast, in terms of work-off breathing, there is a high negative intrapleural, intrathoracic pressure that is generated. And when this happens multiple times like that, there is a negative pressure that is developed and there is exudation into the alveoli. Because of this, it causes the inflammatory process in the lung, and this is known by the terminology called self-inflicted lung injury, which means if you actually leave a patient with increased work-off breathing without supporting it, they will progressively deteriorate, and at one point, even if you support, they will end up requiring mechanical ventilation. So this study looked at three things. One is nasal ALR flaring, sternocleidomastoid prominence during inspiration, and abdominal muscle contraction during expiration. And they found that just tachypnea, these two graphs show that one could be tachypnic but still may not have work-off breathing, and not so tachypnic and still have work-off breathing. So this showed us that actually work-off breathing is what is more important than tachypnea. So that is why when we examine patients with COVID, pneumonia and ARDS, we have to see whether they have these features of increased work-off breathing. Tachypnea can be an additional feature, but in isolation, it does not mean much, and targeting that may not be helpful. The next concept to understand from COVID pathology is, the next thing to understand is COVID ARDS. It's called CARDS, COVID ARDS, is slightly different from the conventional ARDS. Now, conventionally, all ARDS that we know about is what is seen in this slide in the center, which is the phenotype H, where you have very stiff lungs and there is a lot of pressure that is required to recruit the alveoli and generate tidal volume. But when COVID ARDS struck, we realized that probably it forms another, it starts with another phenotype called the L phenotype, where the lungs are not stiff like the H phenotype. The lungs are compliant, which means with lower pressures, you can generate a lot of volume and help in oxygenation before the patient progresses to H type, which happens because of SILI, which we just talked about. And of course, when patients go on to require ventilation and come out, they go into the fibroproliferative phase of ARDS and have residual pulmonary fibrosis. So it is this L phenotype that we are trying to target when we are looking at non-critical care. Hopefully it will stay on now. So we were talking about the L type, H type and the F type. So we have to catch the patients when they are in the L type. So that is where we can really make a difference in these patients, and outcomes are certainly better if we treat them early. So if you put it in a nutshell, COVID ARDS is not a problem of ventilation where you have carbon dioxide problem. So that is where the physiology comes in. When you have problem where some of the alveoli are affected, like in COVID or any other pneumonia, what gets affected is the oxygenation and not carbon dioxide. And it's interesting to look at why that happened. That is because although say 50% of the alveoli of the functional alveoli are affected, 50% are working. Now oxygen will get affected, but carbon dioxide, which is 20 times more diffusible across the alveolar endothelial membrane, will get diffused off. And in fact, you may get respiratory alkalosis because the patient is tachypneic and breathing out more carbon dioxide. So any parenchymal vascular process in the lung will cause only hypoxemia. Now, if the entire lung is damaged in severe ARDS, then even the oxygen diffusion, even the carbon dioxide diffusion is affected, and there can be type 2 respiratory failure or hypercarbia. So primarily in starting till it's very severe, it will cause only type 1, as opposed to motor neuron disease, severe COPD, where there is a ventilation problem. The tidal volume there is low. So even though the diffusibility of carbon dioxide is very high, it cannot match the decrease in tidal volume. So there is hypercarbia with hypoxemia. COVID is not a problem of ventilation because it's a problem of alveoli and problem of vasculature, which causes only oxygenation problem. So what are the things that we can do to help oxygenation? And there is a problem of increased work of breathing. So you can increase, we are breathing 21% oxygen, we can increase the oxygen delivery to the patient. The second thing that helps in oxygenation is PEEP, which is positive end expiratory pressure, which means you give a pressure to keep the alveoli open. So when the alveoli are open, one, they are open, they are stretched and come close to the endothelium, so there is more diffusion, less space. Second, they are open for more time during the ventilatory cycle. So again, more the time, by fixed principle, more oxygen diffuser. So oxygenation is improved. So these are the two things we need to keep in mind when we are tackling patients with COVID pneumonia. Now I'm moving on to some oxygen improving options. Before that, it may be good to recall and understand what is COVID pneumonia, COVID ARDS, and the classification. Now, when COVID affects someone, lung is the most common organ that is affected. When lungs are affected, it may be just not apparent on the X-ray and not causing any hypoxemia, which means saturation is above 94 and the X-ray is normal. This is called WHO stage 1 COVID. Now, when either there is infiltrates on the chest X-ray and it's not CT. CT is the most misused investigation in COVID. Every patient who has got a RT-PCR positive does not require a CT. So now if the X-ray shows infiltrates or if the saturation is between 90 to 94 on air, that is what WHO calls as moderate COVID. Remember, this is not ARDS, this is COVID. Now, when the oxygen level drops below 90% on room air, that is called severe COVID by WHO. And when the PF ratio drops below critical limits like 200, that is called, or there is shock or requiring renal support, these are called critical COVID. Now, these are not COVID ARDS, these are WHO classification of COVID, mild, moderate, severe, critical. Now, when someone's PF ratio, which is PaO2 divided by FiO2, we all have a PF ratio of about 100, which means the PaO2 is, PF ratio of about 5. The normal PaO2 is 80 to 100. The normal FiO2 is about 21. So if you divide 100 by 21, we'll get around 5. 80 by 21 is about 4. So 4 to 5, or some people call it 400 to 500, is the normal PF ratio. When this drops below 300, it is called ARDS. Now, between 200 200 to 300 is called mild ARDS. Between 100 to 200 is called moderate ARDS, and below 100 is called severe ARDS. So that is the difference in the classification between WHO classification of COVID severity and the classification by Berlin's definition of COVID ARDS. Now we look at some oxygen improving options. So we can improve oxygen in three ways. One is awake self-positioning, two is by giving more oxygen, and three is by giving additional pressure to increase the oxygen delivery. So first we will look at awake self-positioning. This is otherwise popularly called as proning. The mechanism by which it works is in patients with ARDS. It is the posterior part of the lung which is predominantly affected. Posterior and bottom part of the lung, posterolateral part. So at that place there is a when we lie down flat, the blood flow goes maximum by gravity to the posterior part. Now that is the part that is most affected. So you have a VQ mismatch. What is meant by VQ mismatch? There is a ventilation perfusion mismatch. Now blood is going more there, but ventilation is not happening because involved alveoli. Now when you put patients on lateral or prone, blood supply changes to that direction, and in these places you have better or less involved alveoli, which can now increase the oxygen diffusion across the alveolar endothelial membrane. Also, when we do that, the recruiting of alveoli which are in the posterior area happen better, which means alveolar which are collapsed now open up because by gravity that part is on top. So by these mechanisms, putting a patient prone or lateral other than supine position increases the oxygenation. So the first method to increase oxygenation is awake self-positioning. Why is it called awake self-positioning? Now proning is a standard of care for critical and severe ARDS patients who are on an invasive mechanical ventilator. But in COVID patients who are not critical or severe, but who are only requiring oxygen or minimal support, not on ventilation, remember these patients are awake. So they can actually change position themselves with some minimal assistance from nurses, respiratory therapists or physiotherapists. So that is why it's called awake self-positioning. If we make a schedule by which we turn the position of the patients over a period of time, that helps in the overall oxygenation of the patient, and that is the primary problem in COVID pneumonia. Now there are several studies which have looked at it from the time COVID came into play, and this is a systematic review and meta-analysis from the All India Institute of Medical Sciences, Delhi, where they looked at all the papers which have reported awake prone positioning in non-intubated patients with COVID hypoxemia. And they concluded that in COVID with hypoxemic respiratory failure in non-intubated patients, there is possibly a reduction in the need for intubation and definitely improvement in oxygenation. But whether it reduces mortality is not very clear. Now, it is a very low risk and inexpensive option, so it is very much propagated and useful. Now, this is what we follow in our, we formed a respiratory intermediate care unit during COVID called the KICU. This is the schedule that we follow there. So we put the patient 2 hours left lateral, 2 hours prone, 2 hours right lateral, 2 hours supine, preferably sitting. So, and every 2 hours they keep changing. So we document beginning saturation, end saturation, which position, and the therapist and the nurse together maintain this. Now we need to be careful that if patients are on lot of tubings, when they turn around, that this should be taken care of. Now some patients, the patients may not tolerate well. Now this is because suppose someone has bit more ARDS on the left side. Now, when you put the patient on the left lateral position, they may actually become more breathless or hypoxic, in which case you need to mention that this patient can tolerate all positions except that particular position. Now, the second thing is, initially when we started this, there was a lot of reluctance from patients to do this. But when we explained to them that, if you diligently do this, you are less likely to worsen and become critically ill, requiring invasive ventilation and probably die, then the compliance really increased and it helped. So involving patient in the decision of carrying out awake self-positioning is very important for its success. The second aspect which helps in increasing the oxygen is oxygen therapy, which is by increasing the FiO2. Now, oxygen therapy is a very common thing that most of us are familiar about, but COVID really helped us to streamline and understand it better, and that is what I am sharing over here. So the indication of oxygen in COVID is when there is type 1 respiratory failure, that is only hypoxemia. Saturations, when we at the beginning of the first wave, our saturation targets were 92, but from oxygen conservation strategies which we put in place in the second wave, the cutoff got changed to 90%. So till someone is above 90% saturation, they do not require oxygen. When saturation drops below 90% and the equivalent PaO2 is 60 millimeter of mercury, okay, normal PaO2 is 80 to 100. So between 60 and 80, there is no need to supplement oxygen. Some of these patients may improve by just awake self-positioning or proning and may not require oxygen at all. So this is what is advocated at home for the patient. If the oxygen drops below 90, obviously they need to come into hospital, have oxygen. And if in case they have type 2 respiratory failure, this is not, which is hypercarbia, which is often not because of COVID. This is because they may have severe COPD, obesity, hypoventilation syndrome, bronchiectasis with severe airway disease with type 2 respiratory failure, pre-existing type 2 respiratory failure. Then we know that giving more oxygen suppresses the hypoxic drive of these patients. So we need to be careful in giving oxygen to these patients, because giving more oxygen will suppress the hypoxic drive. Their hypercarbic drive is already suppressed because they have chronic hypercarbia. So they are thriving and breathing only with the hypoxic drive. So only when the saturation drops below 88 or a PaO2 drops below 55, we should initiate oxygen. So oxygen therapy can be given by either low FiO2 devices, not necessarily low flow, or high FiO2 devices. The low FiO2 devices that we have available are the nasal prongs and the face mask. And the high FiO2 devices are the Venturi mask, reservoir bag, and HFNC, or high flow nasal cannula, which is not very popular, and I'm not going to detail because it consumes a lot of oxygen, and which is not best when we are managing pandemics with requirement of a lot of oxygen. So the sources of oxygen can be oxygen cylinders, or they can be oxygen concentrators, which take the room air, concentrate and give out oxygen, or they can be liquid oxygen, which is in major hospitals where liquid oxygen comes to the wall supply and provides oxygen. Now it's important to plan, source and conserve oxygen. This we learned very much in the second wave of the pandemic, when numerous hospital beds require a lot of oxygen. And despite careful planning, at one point we ran short, and thank God we had a new campus which was coming up nearby, and quickly shifted patients overnight. It was a real hectic task to do that. So it's very important to see how much oxygen beds we have, what is the oxygen supply storage we have, and whether we can match it if all patients require high flow of oxygen. Oxygen delivery devices are put here. This is the nasal prongs. This is a reservoir bag. This is a Venturi device. I will be showing each of these in a bit more detail. Now, the very common thing, oxygen delivery device that is used is the nasal prong. The problem with nasal prong and face mask is that you do not know how much FiO2 you are giving. But there is this formula, which is the rule of thumb, that is very useful, which is FiO2 is 24% plus 4 and the product of x minus 1, where x is the flow. For example, if x is 1, if you're giving 1 liter through nasal prongs, which means that 1 minus 1 is 0, 4 into 0 is 0, 24 plus 0 is 0. And as you can see in this table here, 1 liter is 24%. Say, suppose you're giving 4 liter, 4 minus 1 is 3, 3 fours are 12, 12 plus 24 is 36. 4 liters per minute nasal prong means approximately 36%. It's important to understand this because then you know how much you're giving, and when you're considering oxygen conservation strategies, these become very important. Now, the advantages of giving nasal prong is patients can have their food comfortably. The mouth is free to give food. That's the biggest advantage. Disadvantage is it can cause some nasal sore areas and trouble with some nasal ulcers and so on if you're giving high flow particularly. Second is the Venturi. The Venturi device is works by the principle of Bernoulli's. I'm just going to stop share here to demonstrate that a bit. So this is a paper, and I'm going to blow from here and see what happens. Can you appreciate? I blew from here, but the lower part of the paper actually came up. Now, how does that happen? Blowing happens here. There is a negative pressure that's created below the flow of jet, because of which this part of the paper is drawn upwards. Now, this is Bernoulli's principle. Now, the Venturi uses the Bernoulli's principle in giving a fixed FiO2. So, each of these are given with color-coded Venturi devices, where through that particular hole, a particular flow that is recommended. For example, if you take yellow, you have to give only 8 liters flow through this yellow, which means by Bernoulli's principle, the negative pressure that is created along through these holes will draw in that much of atmospheric air, and what goes to the patient will be exactly 35%. So this is one of the very good mechanisms by which you can give a fixed FiO2. Moving on, this is a non-rebreather mask. It's very useful in giving high flow oxygen. Often it's given with 15 liters to give close to 100%. Remember, the Venturi can give only up to about 60% Venturi. That is what is available in the market. Now, it's important to understand this device a bit more. It has got a mask. It has got 2 valves here. These are expiratory unidirectional, which means they open during expiration and close during inspiration. Then you have a reservoir bag here, which has got a valve here, which is inspiratory unidirectional, which means during inspiration it will allow whatever is here to go there. During expiration it will close. Now you have an oxygen inlet here giving 10 to 15 liters oxygen. Now when the reservoir bag gets filled up, during this oxygen that is delivered inside here fills up this oxygen, and there is high bag and this high quantum of high concentrated oxygen concentrated air in this bag. Now when the patient breathes in, it gives a very high FiO2. When the patient breathes out, it closes, air, the carbon dioxide goes out through the expiratory pore. So by this mechanism, it gives very high flow. Now, when you give lower flow through the oxygen delivery, it can still give reasonably high FiO2, and later I will show how this works in comparison to Venturi and nasal prongs, when we can make intelligent decisions about with lower oxygen, which is the best modality to give high FiO2 in different ranges. So this is called non-rebreather mask. Now suppose you remove these valves, these 2 valves, it is called a partial rebreather. I'll explain that when we come to oxygen conservation strategy. Now when we give high flow of oxygen, an important problem that happens is, remember, oxygen is not is going at high flow and doesn't get humidified by the natural air passages of the nose, because through the mouth also a lot of flow will be going, because of which there is a lot of drying, crusting. Our critical care physicians always complain saying when we intubate patients, there is a block of mucus or crust sitting on top of the vocal cords. What are you guys doing in the ward? So the answer to that is to humidify oxygen. Whenever someone is requiring above 8 to 10 liters for more than 28 to 40 24 to 48 hours, we should give a humidifier where oxygen water is sterile water is filled into this and is able to supply oxygen to the humidified oxygen to the patient. Now we need to keep few things, practical things in mind. If you fill this very high, the tubing water will go, and instead of oxygen, your patient will be getting water, and it will disturb the whole circuit. We should fill it only appropriately, just to above where bubbling happens. But it is important to remember that then, because you're giving high flow, the vapor will soon evaporate. So we need to keep on filling it at least twice a day, if not more frequently, to ensure adequate oxygenation, which is humidified, happens. The risk is bacteria, and more so mucor during the time of COVID, where steroid has been used a lot. So sterile cleaning, repeated changing is the key to prevent that from happening. Bain circuit is a circuit which is very helpful in the transport of patients, not good for very long-term use. To explain it in a brief, it has got a reservoir bag here. It has got a green oxygen inlet through which high flow oxygen goes. Around the green, there is a white tube which takes out the expiratory air, and there is an expiratory valve here where you can adjust and tighten it and give some peep. But remember, the two problems with this: the peep is not measurable. When you screw that bit more, you can give high peep and cause barotrauma. Secondly, when we use this as the mode of giving pressure to the patient, it can cause CO2 retention. So for short term, giving high FiO2 with some pressure, it's best as transport, moving from one place to the other, one ward to the other, moving down for CT, moving from NIV area to critical care. It is probably the best thing, but it consumes a lot of oxygen. Now, few practical considerations. I already mentioned that if we give oxygen by nasal prongs, patient can eat. If your patient is on mask because they are requiring higher oxygen, then mask off, bite, and mask on is a technique that is very useful. You keep food ready, spoonful, mask off, eat, mask back. This helps the patient to be to take adequate nutrition while on higher flows of oxygen. The other aspect that is important is protection of the healthcare worker. Now, masking of the oxygen flow is an important and very underutilized intervention to prevent the healthcare worker. Remember, in COVID, there is oxygen is able to increase the virus particles in the atmosphere in the COVID ward. So when the patient is on nasal prong, there are experiments which have used a surgical mask over the nasal prong, which means all patients who are on oxygen with nasal prong should have a surgical mask over it. This prevents increased virus particles into the atmosphere. It decreases the FiO2 only trivially. Now, if the patient is on a mask oxygen, we can put a surgical mask on the patient and then put the oxygen mask over it. And experiments have found that only 1 to 2% FiO2 is reduced by doing that. So these interventions are important to keep your healthcare workers safe. And obviously, needless to say, that adequate PPE should be provided. I'm moving on to non-invasive ventilation, which is the third strategy to increase oxygenation. Now, we have prone the patient position change, given adequate oxygen. That is also not enough. We need to keep the alveoli open to be able to adequately give more oxygen with the oxygen that you are giving. And also, it can be used as a oxygen conservation strategy. Now, what is NIV? NIV is non-invasive ventilation. Few terminologies about NIV are: one is PEEP, which is positive end expiratory pressure, which is the pressure that remains in the alveoli at the end of expiration. It is the one that keeps the alveoli open. It is also called EPAP in the usual conventional CPAP, BPAP machines. That is expiratory positive airway pressure. The other pressure is the additional pressure or the pressure that you give during inspiration, which is called the IPAP or the inspiratory positive airway pressure. And that is the existing pressure PEEP during end of expiration and the additional pressure support that you give during inspiration. And eventually pressure support is actually the difference of IPAP and EPAP. Now, when you give only PEEP, it is called CPAP, continuous positive airway pressure. When you give both PEEP and pressure support together called IPAP, the device is called BPAP, which is bilevel positive airway pressure. Now, this can be given in ventilator with ventilator NIV mode of ventilator as well. I am not talking about that. I am talking about very cheap, inexpensive 30 to 50,000 CPAP machines and about 80 to 1 lakh Indian rupee, BPAP machines, which can save a lot of lives and prevent patients from progression. PEEP keeps the alveoli open, recruits more alveoli, and improves oxygenation. That is the primary work. Now, if you recall, we told that there are two problems with COVID pneumonia. One is oxygenation. Second is increased work of breathing. Remember, not tachypnea, not just tachypnea, increased work of breathing. So the PEEP helps predominantly on the oxygenation, and it also helps with the work of breathing. Now, pressure support actually increases ventilation, which we already saw increases minute ventilation, which is a product of tidal volume and respiratory rate. And here it increases tidal volume. So by the physiology that we learn, tidal volume increasing actually increases the alveolar ventilation and actually increases the oxygenation also. But it primarily helps in decreasing the work of breathing. Patient is taking a lot of breath. The muscles need relaxation. You give some pressure support. The muscles are relaxed. You are taking over the ventilation of the patient and resting the muscles. But it also helps in oxygenation. Now, there is a diagrammatic way to understand normal breathing, CPAP and BPAP. In the x-axis, you have the time, and y-axis, you have pressure. In normal breathing, this is what happens. When we breathe in and out, at the end of expiration, pressure becomes nearly zero in the alveoli, and it goes up to about 5 to 10 during inspiration. Now, when you give CPAP, you are elevating this pressure. You are saying at the end of expiration, it should not come down below whatever you set, 5 centimeter of water, 6 centimeter of water, 10 centimeter of water. Now, patient normally breathes over and above that during inspiration. Now, when you give bilevel BPAP, in addition, what patient takes during inspiration, you are giving an additional pressure support. So, there is pressure goes so high during inspiration and comes down to your set PEEP or EPAP during expiration. So, this is in a nutshell, very easy diagrammatic way of remembering what CPAP and BPAP involve. Now, going on a little further, we are going to understand what are the different kinds of machines that are available and how we can administer them. So, one is a BPAP machine, or a BPAP machine has both BPAP mode and CPAP mode. In BPAP mode, you can give both inspiratory positive airway pressure, which is EPAP pressure support, and expiratory positive airway pressure, which is the PEEP. Then you can give oxygen, which is entrained. I'll show you pictures. So this is not like the ventilator, which has a blender and gives blended oxygen at FiO2 of the 30 or what you have set. Here, oxygen is in the flow meter in your wall or oxygen cylinder or concentrator. It comes and enters the pressurized air that the BPAP machine is giving. So the drawback of this is you can give only about 50% FiO2 maximum. And next is the CPAP, which also works in a similar way. It gives only PEEP. Again, oxygen is entrained. So here also you can give only 50%. Sometimes with some high FiO2 devices which have external PEEP valve, you can give up to 100%. The last one is the NIV mode of the ventilator, which is not what I'm concentrating on today, but that can give PEEP. You can set pressure support. You can set FiO2 on the ventilator and deliver. So this is not very cost saving because anyhow you are using a ventilator and a critical care resource to give this. So I am interested in Cpap and BPAP as the rescue therapy in a wise, cost-effective setting to save more life. Now this can be delivered through various interfaces. The most common one is the oro-nasal mask that you see here as the second. Nasal pillows are there, full face masks are there, but this can irritate the eye. These patients can, breathe out through the mouth. The last is helmet, which is very good in COVID because there is less virus particles that are extruded into the atmosphere and safe for healthcare workers. But the problem is this requires some expertise which is not available. So the first one that is used is the oro-nasal mask. And in COVID times, you need a bacterial viral filter before the air goes out into the atmosphere. Again, to ensure that less viral particles go into the atmosphere and your healthcare workers are safe. I'll illustrate with a diagram soon. So what are the indications of NIV? You may be wondering, when should I start NIV in this patient? So this is not established literature. This is what we learned and followed, and we are in the process of writing up, and many literature is coming which is around this. So whenever someone requires more than 40% Venturi to achieve targets, and we already saw targets, target is saturation of about 90 in type 1 respiratory failure, saturation of about 88 in type 2 respiratory failure. So even after you give 40% Venturi, saturation is below 90, then you need to give, you need to support that ventilation. You should not wait for 60%, 100% reservoir back. When we go that way, there is already silly that has happened. Self-inflicted lung injury, you're going to have problems, and success of NIV is going to decrease. So early initiation of NIV is the way to save more lives and prevent need for critical care beds, which can be quite challenging to get during this time. The second aspect that we need to target is increased work of breathing. Again, it's not tachypnea. It is increased work of breathing. Again, I've explained that thoroughly. If someone is getting increased nasal breathing as seen by elan nose flaring, sternocleidomastoid mastoid prominent during inspiration, and abdominal muscle contraction during expiration, you need, and any oxygen requirement, even 1 or 2 liters, if you do not tackle the work of breathing, it will lead to self-inflicted lung injury. So in these situations, you should initiate non-invasive ventilation. Now, this is an important diagram to keep in mind. This is the core connection that is required during COVID times to initiate a patient on NIV. We have this mask which goes onto the patient. Normally, there is a vent of this mask. When we give normally for COPD, there is a vent. That is not allowed here. You have to use a non-vented mask, or if there is a vent like here, you have to close the vent. This is because you don't want the expired air virus with virus particle to go out in the atmosphere. So that needs to go through this bacterial viral filter and come out through the expiration port here. So that what goes out is filtered air. Now, secondly, oxygen should enter close to the mask. This will ensure better oxygen delivery, and it will ensure, some people collect oxygen here. If you give oxygen here, it will go out through the exhalation port. It is inefficient oxygen. So you have to give it closer to the mask. So these, putting these in place will use less oxygen, is safe environment for the healthcare worker. Now, after you initiated someone on NIV, when do you wean? Patient is stabilized, which usually happens between, some patients stabilize in 24 to 48 hours. Some patients take about 5 days. The longest we've had is about 10 to 18 days. The longer they stay, they are less likely to come out. So, but about 80% of the patients recover in the first 5 days. So once you are doing well for 24 hours, you decrease the NIV, which means you give BPAP for 3 hours, give 1 hour break, during that time give oxygen. After 24 hours, make it 2:2. 2 hours BPAP or Cpap, whichever setting you reach, and 2 hours oxygen. Then 1:3. Then make them only on oxygen. They are ready to go to the ward. You first wean the oxygen before weaning on the NIV. What I mean by wean oxygen is you come down to lowest oxygen that is required to have your target saturations met. I look at some protocols in this aspect before I move on to the next session. So this is a flowchart that we use in CMC. We start with either nasal cannula or Venturi. and we go up sequentially up to 60% Venturi, but we will start awake self-proning at the very onset when someone requires oxygen, and we'll consider NIV very early here when patient is about 35%, 8 liters. Now, if the patient, some patients we will, because escalation of care is also important, some patient who is 80-year-old diabetic hypertensive would have been decided not on, we will carry on to increase the oxygen to whatever the patient can tolerate for however long. Otherwise, awake self-proning for everyone, early initiation of NIV is the way to go by this flowchart. Now, once you've decided on NIV, how much pressure do you give and how do you go? Again, this is a protocol that we developed. We start at 15 liters because you don't want the patient to be hypoxic. You start at a PEEP of 6, that is essentially in a Cpap mode, and you target SATs. Now, these targets were in the first wave. As I mentioned below, our institution revised the targets to 90 to 94, which was initially 90 to 95 to ensure oxygen conservative strategies are in place. So, there are two targets here. More than 90 saturation, no workout breathing should be there. If these two targets are met, then you don't increase the pressure. Any of these two targets are not met, you increase the PEEP, which means from 6, you increase it to 8, increase it to 10. Don't go beyond 10, because more than 10 PEEP is known to cause barotrauma. Patients with COVID ARDS are already prone to developing pneumomediastinum pneumothorax, which increases when the PEEP given is more than 10. So stop at 10, and if on 10 also things are not all right, what to do I have in the next slide. Now, if they have stabilized by 6 or 8 or 10, about 30 minutes later do an ABG. Look at the PF ratio and then decrease the oxygenation. How to calculate PF ratio, I'll come in a bit, because you're using entrained oxygen. You don't have FiO2, but we have done some experiments to find out what the FiO2 can be for each flow and pressure. Now you come down on the oxygenation if they're doing well. That is what is shown in the left side of this flow chart. Now again, the targets are 90 and 60. These are old targets. So if someone is not or even on 10 PEEP not maintaining saturation or continuing to have increased workup breathing, remember, or both targets should be met. Your oxygen is well, you leave workup breathing, they will worsen because of C. Now you add pressure support. So you reach 10, now you add pressure support of 6, which means the IPAP, inspiratory positive area pressure, is 16 and EPAP is 10. We call it 16 by 10 and keep going up to 18 by 10, maximum 20 by 10. Again, if you go beyond 20 by 10, two things: increase risk of barotrauma, and beyond 20 by 10, if you don't initiate invasive ventilation, recovery after invasive ventilation is poor. So if someone has gone that far, they are candidates for invasive mechanical ventilation if they are for that escalation of care. So once they are stabilized on this, you do an ABG after 4 hours. Now this is important because of the oxyhemoglobin curve physiology we discussed. Saturations are in target, is a PaO2 also in target, and you target a PaO2 of 60 to 90 revised target, not 70 to 90. So 90 to 94 target SpO2, no increased workup breathing, and PaO2 of 60 to 90. These are the targets to be kept in mind while oxygenating and giving pressures for these patients. Referral criteria for invasive ventilation or critical care is when saturations are not maintained despite maximum oxygen which you can give through your wall oxygen, which is 15 liters, and your maximum pressures are reached, which is IPAP of 20 and a EPAP of 10. Or if the patient is not tolerating NIV and is deteriorating, you could use a bit of sedation, and the preferred sedation is dexmedetomidine. Your anesthetist can help with that. That's a very non-sedating, good, doesn't cause respiratory depression and causes enough sedation. Or if the GCS drops less than 8 by 15, if the patient is for escalation, if these are reached, you should escalate for further care. Now, this is some unpublished data that we have from our institution. So we had patients who stepped down from ICU for NIV care, and which you see in the center, and stepped up from the ward. So I want you to concentrate on the stepped up from the ward. This is data from the first wave. Second wave, we had at a given point we had 150 patients. This is totally from first wave. 162 patients. Among this, the black are the failure. 19 patients had to go to ICU. 19 who had NIV a ceiling of care, not for invasive ventilation, died, and one patient who was of full escalation also died. So 19 plus 1 is a failure. If you take that away from the 162, 129 success. So 77% of the patients who received NIV succeeded and came out and went back to the ward. Now there are some more who succeeded who went to ICU. I'm not adding that. I'm purely, we have looked at success of NIV in a non-critical care, respiratory care unit with just simple Cpap and BPAP machines and entrained oxygen. I'm moving on to some oxygen conservation strategies, which is very important, particularly if you are hitting third wave. I've divided them into institutional and individual patient strategies. Institutional strategies are divided into storage and supply and oxygen targets and leaks. Storage is liquid oxygen is probably best to conserve oxygen. You need to have continuous surveillance of oxygen pipes. Any leak should be noted. You can use in the oxygen supply where you can have large head cylinders with multiple manifolds connected. This is best for conserving oxygen. You could use portable bedside concentrator. This can decrease the overall usage of oxygen in your hospital. HFNC and Bain circuit should be avoided, which consume a lot of oxygen. And these are apply more for cold countries where freezing of pipelines can cause decreased efficiency of oxygen. There should be warm sprinklers to increase the temperature of pipes. With regards to oxygen targets in the hospital, there should be constantly teams looking at oxygen target strategies. For COPD, it's 88 to 92. Post cardiac arrest alone, we would allow 94 to 98. In other situations, 90 to 94. There should be close monitoring of SpO2 targets, because suppose 2 days your patient is on 96, 97 on saturation, you are over oxygenating patient and wasting oxygen. Constantly we need to keep coming down on the oxygen, keeping it below 94, because that is enough. And using nurses, we did what is called oxygen rounds. So there will be one group of nurses who go to ward, just their work is only looking at how much oxygen the patient is on, how much saturation the patient is on, should we decrease oxygen. So if you keep doing this, that will overall save a lot of oxygen for the hospital. Now I'm going to explain about 8 individual patient strategies. Some of it we already discussed, so I'm going to run fast. One is awake self-positioning. We know that this improves oxygenation, so it should be advocated in everyone who is on oxygen. It may not have, early on, it may not have mortality benefit. It may not have intubation benefit, but it will decrease your oxygen consumption. So that is lesson 1. Whenever oxygen is initiated, go for awake self-prong. Strategy 2, when you start someone on nasal prong, you need to remember the nasal prong give higher FiO2 for the same oxygen with Venturi device. So in lower flow, you better use nasal prong than Venturi. So that I've shown here, this calculation we already saw when we looked at these individual devices. In the first column, I have oxygen flow and what FiO2 the nasal prong gives. You remember that formula of 24% plus 4 into x minus 1. That formula calculation. And Venturi you have with 2 liter, 4 liter and all. For example, if you see 4 liters, for example, 4 liters with nasal prongs gives 36%, whereas with the same 4 liter, Venturi device will give only 24%. So at low flow, a nasal prong is better in oxygen conservation as compared to a Venturi device. So the second lesson is FiO2 requirement is low, use nasal prong rather than Venturi. Third strategy, reservoir bag. Remember we talked about reservoir bag and I was saying that you need not give 15 liters oxygen, you can give lesser also. Yes, when you give lesser flow, the reservoir bag is able to give higher FiO2 compared to same flow on a Venturi device. But you can even use it only with modest flow. You can't come down too much low. Even in modest flow, there can be what is called oxygen starvation. That is a very important principle which works on, you require a particular flow of oxygen or air, whatever you're breathing. Otherwise, you will become flow starved. So this is a comparison. You have oxygen flow here, FiO2 on Venturi, FiO2 on reservoir bag. So for example, take 6 liters. If you give 6 liters and in a Venturi, you can give 31%. In a reservoir bag, you can give 60%. So this is better in higher flow than Venturi. In other words, if you go by oxygen conservative strategy, Venturi is a useless device. Now, how do you manage starvation? Patients, how do you detect starvation? Patient will become tachypneic, increased work of breathing because the flow that you are giving, suppose you're giving 6 liters through nasal mask, that is all the patient is receiving. What the patient is receiving is not enough for the inspiratory flow of the patient. How do? You remember I talked about this you can remove the expiratory valves of the patient, inspiratory valve, which opens only during, expiratory valve. Once you open this, I told you it becomes a partial rebreather. FiO2 may drop a bit, but still it will be better than a Venturi device, and you can take care of flow starvation. So the third lesson is when FiO2 requirements are high, try reservoir bag rather than Venturi. Strategy 4, early use of NIV, particularly Cpap, not only improve outcome but improve oxygenation as well. We saw the indications. So the fourth lesson is use Cpap early. How early? We saw that earlier here. Requiring more than 40% Venturi, use early. Don't wait for 60 and above. Fifth lesson, when you are using these machines, this you already saw in the picture, use oxygen closer to the mask and use it away from the exhalation port. We saw this in this picture. Oxygen, if enters here and not close to this, you will waste less oxygen. So the lesson 5 is when using conventional BPAP machine, oxygen entry closer to mask, away from exhalation port. Strategy 6. When you are using these machines, use least amount of pressure that is required. Why? See, it is like you giving the analogy is you are trying to enter a road which is having a heavy traffic as opposed to another road which has got less traffic. Which one can you enter easily? The road which has less traffic. So similarly, if you are giving lesser pressure with your machine, more oxygen will enter with just the same flow. So we've actually done some experiments which has proved that, and which also gives you, I was telling you how we calculate FiO2. So this is the oxygen flow, different flows, and we use some test lung and calculate it for different pressure. This is only Cpap 6 to 12. This is bi-level 16 by 10 so on. And as you see, same flow. I'm going to run top to bottom. The same flow with lower pressure, you can give high FiO2 like 30 with 2 liter, 6. As you increase the flow, FiO2 drops. And that is across the board. Say 15 liter with Cpap 6, you can give 97%. When you give 20 by 10, the same 15 liter can give only 54. So the least amount of pressure that is required for the patient you will give better oxygenation for the same flow and hence conserve oxygen. So that is lesson 6. Sorry. Lesson 7, when using balloon Cpap, this is a way by which you can give high FiO2. You give, don't go more than, I don't have time to go into the details of this machine, but when you give more than 40% FiO2, this machine conserves more oxygen than a ventilator. So don't give more than 40% FiO2 on a NIV mode of ventilator. Veins, we already saw, it is better to avoid veins. If you need to give veins, we have come up with a strategy. Veins, the problem is you have to give a particular flow, otherwise the patient will become flow starved. So what we have devised is we put a Y connector. So one of this we'll put into oxygen, the other part we'll put into just medical air, and then we'll connect it to veins. Then you can give adequate flow, but with decreased FiO2, you can give lesser oxygen strategy and still use veins. So if you use a Y tube connector into veins, you can conserve oxygen, but this is possible when patient's oxygen requirement reduces. So now wrapping up with some protocols, putting all this together, I already talked about oxygen strategy protocols, NIV protocols. This is oxygen protocol. Look at the oxygen need of the patient, availability of the devices in your institution, And this is an overarching protocol. You have a patient with COVID requiring oxygen. First thing to do is prodding. Second thing is you decide on your SpO2 targets based on type 1 respiratory failure or type 2. If it is type 1, which is what we commonly encounter, more than 90% FiO2. Whenever you're doing a ABG, more than 60 PaO2. Use a concentrator if available so that you can conserve oxygen. Now, even beyond that, patient requires oxygen, start them on nasal prongs. 1 liter, 2 liter, keep going up to maintain saturation. You can go up to 5 liter. As I told you, Venturi uses more oxygen. So this is probably best. Now, if patient requires oxygen beyond this, it is probably by this already FiO2 40 is reached. Best is to give NIV. By now, you have to make 2 decisions. 1 is NIV available in your institution. 2 is the patient for escalation for NIV. If there is a 80-year-old with comorbidities, we rather give NIV for a patient who is more likely to benefit. Higher age has got poorer outcomes with NIV. So two things to answer. Patient is for escalation, NIV available. You have 3 options. One is the conventional Cpap, BPAP machine with least pressure to maintain target so that it uses low oxygen, or the balloon Cpap. This you should not go above 40% because it uses a lot of oxygen, or the Baines circuit with a Y connector whenever oxygen decreases. Now the patient is not for escalation. It's only for ward-based oxygen care. To change over, and patient is not maintaining on nasal prong, change over to a reservoir bag and start at 6 liters and go up. And if the patient is not tolerating, you take off the valves and make it partial rebreather. After that also patient is not tolerating, you probably have to put them on a Venturi. So this strategy will help in conserving oxygen and giving a stepwise non-critical respiratory care for your patients. Take-home messages are: advocate awake self-positioning as soon as hypoxia occurs. Initiate oxygen therapy only when indicated. Don't start at 96, 94, 93, only when it drops below 90. Institutional and individual oxygen conservation strategy should be in place. Early NIV, whenever they require 40% and more, start BPAP therapy, Cpap therapy, BPAP therapy. Put appropriate pragmatic protocols which should guide escalation and use of various devices, like the one I showed in the previous slide, based on your institution, your center of work and availability and expertise. And ensure that you take care of your health professional well. By the protective measures I mentioned, the mental health and other issues I did, because you need them to take care of your patients. I would like to conclude by this picture from a publication which we did in Journal of Global Health at the very middle of the first wave, where we showed by this game balance, oxygen and NIV are the ones which are easily available and cost effective. Invasive ventilation is resource intensive and the outcomes are poor. So from public health perspective, from individual perspective, institutional perspective, we should concentrate on these which I talked about today, so that we maximally benefit most number of patients, and more patients will receive better outcomes and more lives will be saved. So oxygen and these conserving strategies are precious and they do save lives, but using them with the utmost care, with the knowledge of the physiology and understanding, will carry many more lives. With that, I would like to thank you. If there is another wave that comes, we should be able to take that on with faith, because we believe that with God's grace we have come so far, and with that we will be able to face challenges in the future too. I thank Dr. Hassan, Dr. Debashish Danda and Dr. Robit for giving me this opportunity to speak to you on this.
Thank you very much, sir, for your wonderful talk. There are many questions, around 60. So first of all, I like to hear something from Professor Robed Amin about your presentation.
But overall, it was a fantastic presentation, Dr. Barney. Absolutely brilliant. It's amazing to listen to from the very beginning. And although there was some interruption, but the way you presented this in front of our physician, as well as who are doing a job to deal with the COVID-19 patient, that gives us a tremendous joy, actually. Thank you, Dr. Barney, absolutely. And the way you have presented sometimes started with the physiology and the need for the oxygen and how to deliver the oxygen, especially considering the typing by means of type 1 and type 2 respiratory failure, and also at the same time consuming the oxygen for the hospital as well as individual, and very judicious way of dealing the oxygen. And also sometimes letting us know some of the evidence that you generated in the CMC Valor. It was obviously a fantastic presentation. I was amazed to see and listen to all of this beautiful presentation from you, Dr. Barney. So there's a lot of question I think arises for you, and hopefully Hassan will address these things. And let me ask Dr. Hassan to give the highlights of some of the questions that was asked to Dr. Barney, so that we all can benefit again.
So, Dr. Barney, and also to you, you have to participate in this question answer session. Sir, first question, very basic, to Dr. Professor Barney. Sir, how to interpret or get clinical idea about lung function test at bedside?
Is that question in the context of COVID or otherwise?
Basic question, sir. Just very basic question to lung function test, about lung function test.
So lung function, how to do or interpret? Yes, lung function test can be done in bedside. You think, yeah. So it can be done in the bedside by bedside spirometers. There are very basic ones which can give just FEV1, FVC alone, or you can get a complete spirometer which gives a laptop kind of spirometer, which can give three things. One, it can give a FEV1, FVC, the ratio, and then MMEF and the loop. So the starting of interpretation is FEV1 by FVC, which is the ratio of the volume blown in the first second by the total vital capacity. If that is below 70%, it is obstruction. Now, if it is above 70%, then we look at the FVC. If that is below 80%, it is restriction. If that is also above 70%, then we look at the MMEF. If that is below 80%, it is small airway obstruction. So this is a flowchart way of interpreting spirometry. We should also always look at the loop, which gives a lot of information, our restricted loop, obstructed loop, and more importantly, a flattened loop. Every year we see two patients who have been managed for 10 years with asthma, and we find that there is a tracheal tumor. Because these patients have wheeze, but it is monophonic wheeze, a spirometry loop will show flattening. So these are things to keep in mind.
Thank you, sir. Next question to Professor Mohammad Zubaid Amin. But both of you can add with answers. Professor Zubaid Amin, sir. In hospital, we get many patients, especially female, with COVID symptoms. Their SpO2 more than 94%, but without oxygen, their dyspnea can't be resolved. How can we provide them oxygen?
Now, what I like to mention in this respect, you see, the target of the oxygen should be very specifically seen, that has been presented by Isaac. It's not always that you need to give an oxygen more than 90%, 94%, or 95, 96%. And especially for the prolonged duration of time, because it
Robert, sir.
I think sir has got disconnected. So if I may take over and answer that.
Yes,
so the targets
sure.
are 90 to 94%. So as soon as the oxygen levels go above 90%, we should decrease oxygen. Or if it's already minimal oxygen, we can stop oxygen. So above 90% saturation does not require
oxygen saturation. Hello.
Robert, sir. Robert, sir. Yes.
I'm audible?
I can hear you. Yes, sir. You are.
Yes, I think there's some problem in the network happening. That's the reason why I'm telling you the important issue is to getting the target. The target is actually to get this over 90% will be far better in a patient having a type 1 respiratory failure. And even for the patient who has COPD and having a respiratory ailment, if you get more than 88%, you'll be happy, because the relative hypoxia can give you a good amount of oxygenation, even the life-saving measurements sometimes happen. So it's not always you need to give a 94% or above the oxygen situation, which can lead to even oxygen toxicity sometimes in patients who are giving a prolonged oxygen. So you need to have a fixed your targets, and if you can achieve a stable target above the 90% for more than 24 hours, it's even better to reduce the flow of oxygen as well as the devices of oxygen and get rid of oxygen gas slowly. It has been said that even somebody is having an NIV, if you are giving a prolonged NIV, and then the patient does respond with this small amount, you need to try to revise it slowly so that a gradual hour of NIV will be paused by giving a system of the low flow devices, or even maybe you can take the help from the NRB so that you can gradually wean off or weaning off your oxygen devices. This is very important because in our sitting we found that many times the target was pushed up very high and 95 and 96, and that's the reason why patient cannot be ruled out of the high flow nasal cannula system on NIV for a longer duration of time. This is detrimental sometimes happens in our patient.
Thank you, sir. Over to Dr. Barney. Though this question is not related to today's presentation, but very common and burning issue. 2 or 3 our participants today ask about this. Sir, for preventing lung fibrosis, can we prescribe antifibrotic agents from the very beginning of lung involvement in COVID? Or how to prevent and treat fibrosis? Though it's not related with today's presentation, but we'd like to hear it from you.
Yeah, first of all, I would like to relate it to today's presentation. You give oxygen appropriately, early NIV and early ventilation can actually prevent lung injury and fibrosis. Coming to the crux of the question, there is no role of proven antifibrotic in preventing lung fibrosis. So there are about 6 randomized control trials going on all over the world. We have to wait for the results of those trials to start patients on antifibrotic after knowing that they are helpful. As of date, there is no role to start antifibrotic to prevent lung fibrosis.
Thank you, sir. Professor Robidamin, do you want to add anything with this question about fibrotic? Professor Robidamin? Okay, sir. Next question from Dr. Kamal Parvez. Sir, prone positioning is indicated in hypoxic COVID-19 pneumonia, but contraindicated in pulmonary embolism or pulmonary edema. COVID-19 may have respiratory failure due to pulmonary embolism or pulmonary edema. How to differentiate between above conditions? Dr. Barney.
So, as I explained in the physiology, the proning is to improve the VQ mismatch. Now, when you say it's contraindicated in pulmonary embolism, it is based on where the embolism is. Suppose the embolism is in the posterior aspect, then when the patient lies down, more blood flow to the posterior, more VQ mismatch. Actually, proning will help. But if the embolism is more in the anterior vasculature, it will be the other way. So, it is not dogmatically correct to say pulmonary embolism proning should be avoided, but proning helps in ARDS. It may help in other respiratory conditions as well. For particular patients, it may not help. So it is based on where the physiology is involved and how it will benefit. So we'll have to try it and then see how it helps in individual patients. We know that ARDS is predominantly posterior and hence it helps in COVID ARDS.
Next 2 questions to Professor Robidamin, sir. Sir, are you hearing my question? Professor Robidamin, sir. Okay. Next question to Dr. Barney. Sir, some COVID-19 patient after discharged, they again come with decreased SpO2, around 88 to 90%. Then what should we do for this patient?
2 scenarios in this question. One is sometimes patients may go with only about 90%, they may not be ambulating at home in the hospital. Now they go and resume their normal activities. There is exertional desaturation. Now that, if it is significant, then we need to prescribe what is called SBOT, short burst oxygen therapy. That is, when they walk, they take oxygen and for 5-10 minutes, and it will settle. So during exercise, oxygenation or post-exercise. The second scenario can be patient is going well with good oxygenation and develops new onset hypoxemia. The common cause for that, there can be several. Common cause is pulmonary embolism. We know that COVID is a pro-thrombotic state, and often patients who undergo quite severe COVID illness, there may not be facility to do a CT pulmonary angiogram. They might have even received therapeutic anticoagulation during the hospital stay, but they get discharged without anticoagulation. Then they can present with pulmonary embolism. So we probably need to do a chest X-ray to look at supraortic infection, mucormycosis, and so on. But if those are not there, we should consider doing a CTPA to look for pulmonary embolism. On another hand, from a preventive point of view, if someone has received therapeutic anticoagulation during COVID, we should either do a CTPA at discharge to ensure that they don't have a embolism to continue anticoagulation, or in some patients there is a role of giving low dose aspirin for 3 months to prevent occurrence of pulmonary embolism. These may be preventive measures that we can take.
Thank you, sir. Next question to Rebreather Mask, sir. Mentioned his name. To Rebreather Mask, sir. Sir, is there any role of hydrogen therapy in COVID-19?
Okay, good question. I will just, before answering this question, I would like to give some of the highlight to the physicians who are actually say something about the proning that has been said by Dr. Barney very likely. You see, when we are doing the proning, he said one important issue is the self-proning, especially in the awake position. Now, this has been proven in the many areas, and there's many literature on the part. Fact that sometimes the patient may be completely obese and may not be completely cooperate during the time of self. So they used to have hospital has a proning team. Unfortunately, in Bangladesh, we do not have any very good proning team which can help the people to go for the awake proning. So self-awake proning is a very good one, I will say that, as because mostly the areas will have a collections of the fluidity or the part of the dorsal region. And you always know that during the time of supine position, heart has also its own weight, so that you can easily see that there's a big trouble happens with the VQ mismatch as well as weight of the heart, which can have a very difficult breathing. So when you sometimes prone the patient, the weight of the heart will be released and the rest of the VQ mismatch will also be gone. And then on the other hand, 2:1, I mean, if you go for a 16 hours of that position and then make again the supine or lateral position, there will be always the changes of the shift of the fluidity, which can lead to the expansions of the different alveoli. So that's the reason why awake proning is very much helpful, especially for the COVID-19 patient. In addition, what Dr. Barney was saying is absolutely correct. Now, regarding the hydrogen therapy, what I like to say that one of the important catastrophe in the COVID-19 happens in the second week is due to the cytokine tsunami or, cytokine storm. Now, there are many of the interleukins that has been said to be responsible for this, like interleukin 6, 8, and 10. And mostly these are secondary to a syndrome known as macrophage activation. And that happens mainly in the pulmonary level. So there are several therapeutic trials has been aimed actually control this immune storm, which is in progress. Like we have given the IL-6 inhibitors, corticosteroids, such thing. Now, molecular hydrogen actually acts in the final pathway of this complex inflammatory cascade. And this actually inhibits the cellular action of reactive oxygen species. You all know that reactive oxygen species is mainly responsible for such amount of inflammation and damage to the lung tissue. So if we can combine the nasal oxygen therapy with hydrogen therapy, there may be a worsening respiratory system can be prevented. That is the hypothesis why the hydrogen therapy has been came up in the literature. There has been some trial is going on. We are not sure what is going to be happen with this trial. And although there are a few trials which is single arm, but the dual arm will give us really good picture what the hydrogen therapy can came up in future. So that's a good question, I would say, a very good academic question, but still we don't have any high quality evidence about the hydrogen therapy in COVID-19. I think there is another, Yes, yes.
Sir, I'm
Okay,
coming
please.
to you, but sir, I like to ask one question. This question is also out of today's track, but curious mind. To Professor Barney, sir, what's your experience or your institute experience about use of remdesivir and steroid in COVID-19?
The use of steroids has
And
been
remdesivir. Okay, sir.
so I will start with steroids because that is more
Okay, sir.
promising. After the recovery trial and subsequent trials, giving steroids has been of paramount importance in COVID. But appropriate initiation is very important. Because of inappropriate starting and inappropriate dose, we saw after COVID wave, we saw a mucormycosis wave. That should not happen. So we start oxygen, we start steroids as per recovery trial, which is only if the patient becomes hypoxic, is there an indication to start steroids. Without hypoxemia, that is below 90% saturation drop on room air, there is no indication for steroids. And the dose of dexamethasone 6 milligram for 10 days is what is indicated, and we should stop after that. Very rare instances when patients have had critical ARDS where the lungs are pretty bad, we have continued the steroids for few more days and gradually tapered over like 1 month duration, but that is anecdotal. But giving appropriate dose for appropriate duration is got best efficacy without the harm effects of steroids. With regards to remdesivir, it came in a big way, but then subsequent trials have had not much promising results. So we did use a lot in the end of first wave, beginning of second wave, but currently the indications of remdesivir has come down. WHO has taken it off the label. So currently patients are indeed progressively worsening hypoxic and we are starting on steroids. To a subset, we do give remdesivir because the concept of you giving steroids without giving an antiviral, whether it will produce a increased viral response is there. So we are giving remdesivir to a subset, but I'm not sure it's backed up by strong evidence as of date.
Now over to Professor Rebreather, sir. If you like to choose any particular questions or few questions, it's up to you. Which you think that?
No, I think the importance of the oxygen, even the steroid as well as the remdesivir has been very nicely highlighted by Professor Barney. What I want to emphasize another point on this corticosteroid that do not use the corticosteroid in mild to moderate cases, which is very important because we have seen that many of the times there is a temptation to use the steroid, even though there is no indication. You see, the hypoxia should be the important indicator and not to judge that by means of fever and others. That's because we are going to deteriorate the patient. As because the first week is a viremic phase, and that very correctly says by Dr. Professor Barney, if you use the steroid without any antiviral, you are just promoting the more viruses. And it has been detrimental. And that is the reason why WHO is saying in their document that if you use the steroid without indication is not only detrimental, it increases the mortality. This is another point. And about the remdesivir, I would say that there is a very narrow area where the remdesivir can be used, as because there will be always an area where the low flow oxygen demand is needed for the patient. Patient is at the verge of the viremia at the day 6-7, and fever is not going down, and the patient having a cough and respiratory trouble. And patient may have a hypoxia to be started very soon, just about 1991. I think this is the area where the remdesivir can be given and give as benefit. But if we choose to give the remdesivir in a very late stage, I mean, when the oxygen demand is too much high, I'm afraid it will not work too much good. And sometimes the papers have a dictation of different etiology and the meta-analysis is not good. But if you follow the SCT trial 1 very carefully, you will find a very narrow space where the remdesivir is beneficial to patients with COVID-19. And there are some questions relating to the part of dual oxygen therapy, especially. I would say that the NIV has been very highlighted by Professor Barney, and this is not the COVID-19 only. It was also been shown in the 2003 in the SARS and also in 2012 in the MARS, where the early NIV introduction has been found to be beneficial, improvement of the mortality issue as well as the morbidity issue as well. But unfortunately, this COVID-19, we found that there's a introduction to the high flow nasal cannula. It takes and drives all through Bangladesh, and people are trying to use it by any means of high flow nasal cannula. And lately, we found that the hospital consumes so much of the oxygen in their liquid tank that the normal people who need a low flow or low high rate oxygen suffers a lot. So that's the reason why institutional oxygen conservation therapy, which has been very rightly said by Professor Parni, is very important. And that is the reason why I was advocating to use this NIV in our settings. And even we can use it in our small territory of district hospital and even the Upachala primary healthcare hospital, where you are not getting a lot of oxygen consumption through the high flow nasal cannula. And we can also use the manifold system and then utilize this to the part of the NIV for this use. Now, there are some questions arising on the part of dual oxygen therapy. But I like to mention that during the time of NIV mask or even the tubing, there will be a small group of patients, especially elderly people having a serious hypoxia, will not have a complete resolution to the FiO2 improvement. In that case, some of times the dual oxygen by means of additional NRV or by means of face mask has been shown to have improved oxygenation. This is called the dual oxygen therapy. But remember, this will be needed only around 5 to 6% of the patient who needed severe hypoxemia and not responding to the part of the NIV. So this is one question. Another very important question that easily came up to our mind is the oxygen toxicity. And I do believe that in our perspective in different hospital settings, there is many people who cannot be relieved from the oxygen because they develop oxygen toxicity actually. If they relieve the oxygen, they get more deterioration. Even with oxygen, they are not getting a good amount of oxygen relief. This is the oxygen toxicity. I would say that it has the serious effect in three principal forms. One is the central nervous system, which causes the convulsion. Second is the pulmonary lung system, where there is a difficulty in breathing and pain happening in the chest. And third is the retinopathic system, where the alteration of the eyes happen. We all know these three very important issues. But important thing is that the earlier part can be detrimental as because pulmonary damage in the form of atelectasis as well as the tracheobronchitis inflammation by a free oxygen territory is very detrimental and some can lead to hypoxia, acidosis and death. Although the eyes are not very accurate sometimes, but it has been observed that twitching, convulsion because of the toxic effect on the part of enzyme in the central nervous system can be also detrimental in acute hyperoxic therapy. Besides this, I would say that retinal damage, also there are erythrocyte hemolysis happen. Many times, if you continue to give the 100% oxygen, it can lead to myocardial damage. There are some endocrine effect in the renal gland. Sometimes the gonad can be affected. If I am not wrong, Professor Parni can also correct me. And also the thyroid gland can also sometimes seem to be affected by serious amount of oxygen toxicity. The renal damage has been also been reported in many case reports, a hepatic effect and the chemical toxicity leading to any cell death can also happen if somebody has having a serious amount of oxygen toxicity. So you can see the oxygen is a drug. It has to be used judiciously. It's a pharmaceuticals use, and every drug has some adverse effects also the oxygen. And that is the reason why our aim is to educate our people not to use it injudiciously oxygen in their home territory always, because this is a drug, it has to be prescribed by the physician.
Okay, sir, last two questions. If we start asking all the questions, we may not conclude it in whole night. So last two questions. First question to Dr. Parni. Sir, can we use extracorporeal membrane oxygen in COVID-19? What's the outcome?
Well, the window of ECMO is very narrow for the patients who have very severe ARDS. But the most important thing is the success that it has is only in centers which are exclusively doing ECMO therapy in a certain number of beds at prolonged periods of time, which means they have enough experience in ECMO and handling such patients. Only in those setups there is a benefit in severe ARDS where we rest the lung, giving time for the ECMO to take the action of the oxygenation while the lung recovers. But it cannot be initiated in smaller or even larger setups which do ECMO once in a while. It will not have the narrow benefit that it can offer.
Thank you, sir. Last question. First to Professor Rebreather, sir, and Professor Barney can also enlighten us about this issue. Sir, question is, many ask about this. Sir, role of TOSI in oxygen demanding COVID patient. Do you use secukinumab instead of tocilizumab?
Okay, I think this is not related to the part of the subject. Still, I would like to say that tocilizumab should be used in patients whom you need it. It has been said that the patient who needed progressive oxygen demand, even on the patient who is having from low FiO2 to high FiO2, that's been shown by Professor Barney, will be an indication to receive the tocilizumab, in addition to the part of steroid as well as the antiviral. So it's an additional drug, an adjuvant one, rather than a solitary single one. Secondly, the patient who's actually failed on the part of NIV or high flow nasal cannula and about to go to the part of the mechanical ventilation will be a good candidate. But the fact that as early as possible you can give it, if it is possible to give it within 24 hours of time, that will be highly beneficial to give the tocilizumab. The meta-analysis and other of the tocilizumab was found to be very beneficial at the end, and so it will be better if you can give it early. And besides this, the other drugs which has not been highly beneficial to be found in clinical trial should be in reserve. If somebody cannot have in hand about this of tocilizumab in hand, then maybe you can choose the other drugs to be given. Another drug which is a baricitinib, I think that also is right now in the picture. You can also combine it if you combine the give with a remdesivir. But before that, we must be sure that the patient receives the steroid. That will be an indication to give the baricitinib injection. I think Professor Barney can also add please.
I don't have anything to add except that the tocilizumab, the first 24 hours is very important of acute deterioration despite being on NIV and so on, because the early window is lost, then the benefit is not being proven. And there are some instances where this kind of delayed cytokine storm that hits and tocilizumab is not available. We have wondered and occasionally used steroids in the high dose steroids in the place of tocilizumab as a replacement. So we have taken the exact indications of tocilizumab and given a pulse dose of steroids. It's anecdotal, but we have looked at the similar indication and given with the hope that it works in the same way. So in some places where it's not available, it can be an option.
Thank you very much, sir. But I have to take another question from Facebook Live, and after this, our chairperson will conclude the session. This question is for Dr. Barney. Sir, question is, what is the most appropriate position just after proning position? And with this, how long it can be? At a time, how long proning position can possible?
So what is the best position after proning? Whichever the patient is comfortable with, left lateral or right lateral. I don't think there is a this way, that way answer. It is important that changes in position happen because, as rightly the question points, it's not possible to lie down when awake and not sedated in prone position for 18 hours. It's not possible. So it's important to rotate. And most studies which have looked at it have changed the position approximately half an hour to 2 hours. So every half an hour to 2 hours, at least half an hour, patient should be on that position, and preferably not more than 2 hours, so that the change of the VQ keeps happening. So with regards to prone alone, probably the patient is able to lie down if they're able to tolerate up to 2 hours. Not tolerate, half an hour would be ideal. But like Professor Rabib mentioned, some patients like obesity, they just cannot be prone. So you just manage with left lateral and right lateral and sitting up and keep changing this.
Thank you very much, Professor Barnett TJ Isak. It was an excellent session from you and wonderful question answer session. Thank you very much from the heart of BD Physicians. Now, I like to invite our today's chairperson, Professor Mohammad Robaid Amin, to conclude the session.
Oh, thank you, Dr. Ehsan Khan, the BD physician, for allowing me to give a chair on a particular session which has been enlightened by Professor Barney T.J. Isaac from the CMC Fellow. It was wonderful to listen to a very time-demanding issue on the part of oxygen therapy and then IV, especially non-critical respiratory support for our physician. I would say that our physician would become very benefited by his wonderful lecture and a wonderful review, starting with the physiology and up to the part of clinical context, and also at the same time helping the institute as well as nation for conserving oxygen therapy and promoting how to provide the oxygen appropriately in the patient hypoxia. So this is very important. And secondly, there was a lot of question arising which indicate his ability to generate so much interest. And I was delighted to find him as a wonderful and also help him regarding the many answering the question. And if you can continue, I think the night will be goes along. But I would say that for our physician and the students, we try to collect this lecture and try to listen it repeatedly, because he has been given whole through and through. So every minute will be count. If you listen to it second time and third time, maybe get points, because a single lecture for longer duration, you may not get everything in your capacity of the brain. Our aim is to a few things. One thing, we're still dealing with the COVID-19, still it has been in the part of the third wave, and still we need to save many of the patients if we can properly, judiciously give the proper supportive treatment for the COVID-19, which is the main aim. So I think this lecture, at the same time, the question answer session will be a lifetime learner for many of our physicians and students that has been watches Professor Barney T. Isaac on this particular day. So I'd be more and more interested to listen to him always. It gives us a pleasure actually to learn something from an I will say that a pulmonologist from our very neighborhood country. And if the situation becomes improved, we'll be delighted to come here and see you in front, and so that we can listen to you in front of with you. Very nice piece of lecture. Thank you very much, Professor Barney, for enlightening us. And I also give another thank you to BD's physician and the sponsor, and also especially the Ehsan Khan and our very honorable and responsible listener, especially the students as well as the physician of our country, who has through this long hour of 2.5 hours listening to this wonderful webinar arranged by the Ehsan Khan. Thank you very much for also allowing me to become the chair.
অনেক লাইভ